Dr. Abhijit.
Good evening, sir, all the respected professors. I must thank all the IAP office bearers and Rajendran, sir, for giving the opportunity to moderate the session. I am also one of the co-learners. This is for the PGs there. So we'll be just having a healthy discussion here. So don't get tensed and just do it with the routine flow. And my regards to all the respected professors. PRC sir was himself my examiner during my postgraduate final exams. So I'm really happy. Thank you very much, all the professors.
Thank you, Dr. Divya. You can start your presentation. Unmute.
Yes, all the best, Dr. Divya. Start.
Good evening, professors and postgraduates. I'm Divya. I'm presenting a case of a 10-month-old female baby named Asha. Date of birth was 3/10/2020. Date of admission is 17/7/2021. Date of examination is 10/8/2021. She comes from Tengambuttur. Informant is mother and history is reliable. She came with complaints of chief complaints of cleft palate noticed at birth. There was congenital heart disease which was noticed at 25th day of life. Complaints of not attaining the developmental milestones as compared to the elder sibling. For the above complaints, the baby was referred to our institution for evaluation and management under the RBSK scheme.
Yes.
History of presenting illness. As the complaints was noted by mother since birth and starting the history from the antenatal period. Antenatal history, the obstetric score was P2L2A0. This baby is a second born to the mother at the age of 30 years out of non-consanguineous marriage. She conceived spontaneously 2 years after the first delivery. First trimester, she was booked at Rajakamangalam PHC at 6 weeks. She was started on folic acid supplementation then. There was no history of fever with rash. There was no exposure to teratogens like radiation or drugs. And first trimester scan was done and live intrauterine pregnancy was confirmed. Second trimester, quickening was felt at 20 weeks of gestation. Iron and folic acid supplementation was started at 4th month and calcium tablets were also started. 1 dose of TD vaccine was taken and there was no history of gestational hypertension, gestational diabetes mellitus, bleeding or leaking PV or polyhydramnios. Second trimester scan was taken and no anomalies were detected. Third trimester, the fetal movements were normal and there was no history of gestational diabetes mellitus, gestational hypertension, leaking PV, APH or febrile illness. Third trimester scan was taken, it was normal. At 38 weeks of gestation, elective LSCS was planned. As the mother had CPD and she also had a previous LSCS, it was done in a private institution. Natal history, she delivered it.
Dr. Divya,
Yes, ma'am.
you hold here. So
Yes,
you have described the pregnancy period. What else could have been added? What else, the practice-wise, what could have been done? Suppose you are given one more chance to redo this case, what else you can add?
We can add the maternal weight, pre-pregnancy BMI can be added.
Yeah, weight gain. Weight gain during pregnancy, which has to be proportionate to their BMI. So pre-pregnancy weight or the first weight that the mother is remembering. And her height is not going to change. So the BMI and whether she gained adequate weight. Very good. What else could have been done in the practice? They did fairly good. They did all the scans and the supplements and all. Anything? Nusha or Anjana would like to add? That is the primary prevention of birth defects, isn't it? So ideally, the folic acid could have been reconsidered. But this, so then you have to say this was an unplanned pregnancy. Only if it is a planned pregnancy, you may be able to do it. Or secondary prevention, always they do. When baby is affected, mother is having other risk factors, she's on valproate, etc., etc. So these are the two things. And what is the dose of folic acid for primary prevention? What is for secondary prevention?
For IUP, it is given as a 60 milligram of elemental.
No, I am asking only, listen to the question and answer. Folic acid, what is the dose?
For secondary prevention, 500 micrograms can be given.
No,
Which is
no.
5 mg.
No, that is not the global recommendation. Would Anjana like to answer? For primary prevention, it is 400 microgram. And for secondary prevention, it is 4 milligram. But the companies are producing 5 milligram tablets. Actually, it is much higher than the tolerable upper limit. Suppose you give extra high levels of folic acid. Is there any danger? Any caution that you have to take? Every day you are taking much higher, 5 times the tolerable upper limit. 1 milligram is the tolerable upper limit. And this pregnant mother needs only 400 microgram. But she is taking 5 milligram per day. Any danger? It can aggravate the B12 deficiency. If the mother, so whether she is B12 sufficient is also very important. Who will be B12 deficient? Which type of mother will be B12?
Vegetarian.
Others are vegetarian
or families with any genetic vitamin B12 deficiency.
Yeah, you decide among yourself who is going to answer. Don't shout as quorum. So you can decide, I am going to answer like that. Or when you ask. Okay, so B12 sufficiency should be ensured when you are giving lot of folic acid, high doses. Because in the pathway, there is a folate trap if you give more, and B12 is needed to recover them. So B12 may be channeled into recovering folic acid rather than doing its own function. So it can aggravate the B12 deficiency. So in strict vegetarians. Okay, that is why the United Nations antenatal multiple micronutrient preparation is having 9 vitamins and 5 minerals. It can be used as a sprinkles along with the salad or whatever she's taking. That has even folic acid and B12 are there. So this is it. I would like to call the other moderators.
Yeah, you have told about the vaccination of the mother. What vaccine?
Yeah.
TD vaccine she has taken, sir.
Now you have asked only about the TD vaccine, but do you want to ask any other vaccine should have taken as adolescent, all that? When it's coming to congenital malformation?
IMRs.
So you would like to know also whether mother had previously taken, not during pregnancy, her past immunization status also, whether she has been vaccinated with the rubella vaccine or varicella vaccine or the MMR itself. MMR has been available for quite some time. So these can cause congenital malformation. So you can ask that history also, or older history. And this is there any other vaccine also that is recommended during the pregnancy? Now, especially at this contemporary period, is there any vaccine?
COVID vaccine, sir.
Because this is in a case that is contemporary, no? Recent one.
Which vaccine?
COVID vaccine, ma'am.
Yeah.
Yeah.
Yes, Dr. Abhijit.
No, ma'am. I think she has covered from neurological.
Now you go to the birth history. Okay.
Now the scans also, the mother is 30 years, no? So she becomes high risk for malformations. Understand? So whether an anomaly scan was done, because she has undergone a pregnant.
No, sir. Anomaly scan was not done, but second trimester.
You could highlight that also,
Yes.
because cleft lip and palate and is a one which anomaly is one that can be detected antenatally.
They didn't detect it.
They didn't detect it.
3 scans were done, but they failed to detect.
So are they look for, if they had done a cursory scan only looking at the placental position and fetal well-being, they would have missed. Understand? So being a 30-year-old mother, probably they must have thought of doing an anomaly scan also. So they could have been picked up in the antenatal period. Huh?
So they usually do only the obstetric scan.
Yeah.
Yeah, continue. Natal history. Now we are eager to listen to you. Okay, continue.
She delivered a term female baby of birth weight 2.8 kgs through LSES. Baby did not cry immediately after birth, and resuscitation was required, and the measures of the resuscitation of the is not neonatal.
At this
Now,
context, any other history you would have asked? Baby did not cry after birth, at birth.
History of meconium aspiration.
Meconium stain liquor. Okay. Then?
It should have been a surprise. No, this is an elective LSCS. And in an elective LSCS, to have a baby not crying means probably the intrapartum monitoring, probably they would have missed something or not done as per guideline. They have put a partogram is very important. And here because this is a baby that is asphyxiated, electrical, you also can comment on, though it's elective LSCS, whether mother had been having pain also, whether they have assessed fetal well-being just before they take up elective LSCS.
Rightly said. That history you could have asked. So
and the anesthesia that they had used also, that would have probably depressed the child and not made it cry.
Yes. So whether it is only natal asphyxia or prenatal, that part, that story we could have asked and highlighted. Okay, continue. Continue.
Neonatal history, baby was shifted to NICU in a nearby private hospital, and baby was in NICU for 35 days. Started on IV medications and respiratory support was also given. Other details are not known. Baby noticed to have cleft palate and no other external anomalies were noted. Baby tolerated express breast milk, which was started on 7th postnatal day with Haberman's nipple. At 2 weeks, she was told that express breast milk was not sufficient and formula feeds were started. There was no history of seizures or neonatal jaundice.
Okay, what is your, go back to that slide. Suppose you were the treating doctor. What feeding advice or how you would have managed this baby? This, of course, what is your comment on this? Is this good practice or?
No, ma'am.
IVCF practices.
Bad practice. Colostrum should have been given, ma'am. And direct breastfeeding should have been initiated.
Here, what probably we must think of was maintaining lactation when the baby is sick. Here is a baby that is in NICU. You don't wait for the baby to get well and then start on feeding. Actually, you must start your work on promoting breastfeeding, that is massaging the mother's breast and then expressing the breast milk, and so that she starts initiating secretions. So the secretions are maintained till the baby is becoming well and then utilizing that milk. So that aspect they should have taken a little more care. Otherwise it ends up, suppose suddenly on 25th day, you are giving a baby suddenly to mother to feed, a mother who has not been feeding the child, it ends up with lactation failure only. Yes. So to prevent that, they should start maintaining lactation for every sick baby that is there in the nursery. Okay.
So what are the what centers we should have for that? Sir is telling the ideal situation. Excellent. So what units they should have? Lactation? Lactation management centers or lactation management units should be there, where the mother can express and it can give to her own baby, or she can even donate, no? So donor milk. What is the name? What is the
pasteurized donor human milk?
Pasteurized donor human milk. So they could have thought of that. So here the IVCF practices had collapsed. You said direct breastfeeding. So what do you think in a cleft palate?
Using 5-finger technique, we can advise.
It is possible, okay, but somebody should be trained in that. The skill should be imparted to the mother. Can you explain what is the 5-finger technique for direct breastfeeding?
Usually, the breast will be held by 4 fingers, but here the breast should be held by 2 fingers, and the index finger and the thumb should support the chin of the baby.
No, not that. With the 5 fingers, that is Dr. Mallikarjuna from Karnataka. He has got 32 babies, or more. Now the series may be more, all with cleft palate and all doing exclusive breastfeeding. That is, you place the baby's mouth above the nipple and then push the breast tissue with the 5 fingers. Support with one thumb, and then for the 4 fingers, you push the breast tissue to occlude the defect as a cushion. And then the baby can feed. That is their experience. Okay.
The areola becomes the obturator. Okay. Natural obturator that goes and, as Madam has said, closes the defect in the palate and then helps and aids the baby to suck well.
Yeah, that is.
Dr. Divya, what is the significance of feeding being started on day 7? What is your take on it?
Sir?
With the history of birth asphyxia, if the feeding is started on day 7, so what is your take on it?
Does it have any prognostic indication?
Feeding should be initiated earlier. Should have been initiated earlier.
No. The baby fit for feeding only on 7th day. Sir is asking, does it have any significance?
What would have happened?
Baby, respiratory distress.
No.
It directly corroborates. I'll answer it for you. It directly corroborates with the element of hypoxia, the hypoxic damage to the brain. So you can gauge on that. So in your practice also in future, you always remember, whenever parents say baby had birth asphyxia, you always ask them on what day of life the feeding was established. So if they say within 24 hours, 48 hours or more than that, then that helps you to gauge the severity of hypoxia. So here, if it is started on day 7, that says that hypoxia must have been a severe kind of hypoxia, even if you don't have the Apgars and all.
So that's a prognostic
that has
indicator,
that has a huge prognostic
prognostic indicator, and also the immunity, the passive immunization transferred to the baby was affected. Trophic feeds were not given. So all these are going to have, and the microbiota, the gut microbiota are not going to change. So all these are going to have long-term consequence on the baby. Continue.
Had it been you in the delivery room and you know that the baby is coming with the birth asphyxia, as per the American College of Gynecology guidelines, what you would have documented in the delivery room in order to see the severity of hypoxia, whether it is an antenatal hypoxia, perinatal or postpartum hypoxia, how you would have acted in the delivery room? What is that one test? Tell me that one test.
Any surrogates or anything?
So cord blood pH is one of the significant markers which tells us that the hypoxia has happened in the antenatal period. So that is as per the American College of Gynecology criteria.
Yeah, that is the surrogate marker that we can do. Huh?
Yeah.
Okay, continue.
Baby was detected to have congenital cardiac defect on 25th day of life during the NICU stay, which was confirmed by echo, and she was asked for a follow-up later. Baby was shifted to mother's side on postnatal day 36. As per mother, weight gain was noted. Baby was not initiated on direct breastfeeding, and baby was on full formula feed at the time of discharge. No details regarding the newborn screening is known.
Here you can take some more details of the formula feed.
Now, you have any comment on which heart disease in an NICU gets detected so late? Every day the baby is seen thoroughly. No, every day they would have been auscultating. But clinical suspicion of an heart disease is coming on 25th day here. So what do you think? What all diseases can probably present only on 25th day, or whether baby was examined thoroughly only on the day that the baby postnatal ward discharge or discharge was planned?
Probably it was a shunt lesion, sir, which got manifested later.
Which shunt? Right to left, left to right?
Left to right. Because pulmonary pressure gets reduced at that time. So
Yes.
Good. Because of asphyxia, there is high pulmonary pressure. So the shunt is not happening. Once the pulmonary pressure starts falling, the shunt becomes significant.
The shunt becomes evident.
Murmur. So it could be simply be an VSD, no? That could start becoming clinically manifest very nicely little later, not soon after birth. Okay, then?
There have been PDA also.
It could be a PDA that has got opened up little later because of inadvertently too much fluids administration, or because baby had been on ventilator, their auscultation would have missed, no? From the ventilator sounds, the PDA sounds, okay?
Or even it was communicated late to the family also, it can happen. No? The doctors would have been documenting it, but the communication, this is from the mother, no? We are not having the records.
So it could be ASD also, that could present little later. Huh?
Yes, formula, but the best is MOM, mother's own milk, express breast milk or direct breastfeeding. Then next is the PDH, that is pasteurized human milk. The third is formula. Okay, they went for the formula now here. Huh? As sir was telling, the lactogenesis was delayed, and finally the lactogenesis was also failed lactogenesis. Formula, what question you will ask?
The dilution of the formula should be
asked. Did you ask?
Yes, ma'am. Yes, ma'am.
What were they giving in the right dilution?
Yes, ma'am.
What is the right dilution?
30 ml, one scoop.
Yeah, Ramachandran sir is asking, did the child have cardiac symptoms? You are coming to that?
Yes, ma'am. I'll be explaining it, sir.
Yeah. Continue.
How many grams spoon is there with the formula? You said 30 ml and 1 scoop. So how many grams?
Around 5 grams.
It is 5 gram. It is 5 gram. Yeah, that's correct.
Continue.
Mother was continue the baby on a formula feeds with using Haberman's nipple till 8 months of age, and she gives history of occasional regurgitation and choking of feeds. The other details are included in the dietary history, and there was also history of hospitalization at 6 months, twice for cough and fever. Hospital stay lasting for 1 week each.
What would have been that?
And the baby had cleft palate, so it could probably could be an aspiration pneumonia.
Something else in the element of hypoxia, which must have had contributed to this aspiration. Yeah. What is it? Yeah, right. Yeah, that's right.
Oropharyngeal incompetence.
So oromotor. So, yeah, right. Yeah. Oromotor incoordination, which contributes to it.
Yes. Continue.
There was no history of dyspnea, sucrose cycle, increased forehead sweating, or edema, which is suggestive of CCF. There was no history of cyanosis or cyanotic spell, suggestive of cyanotic congenital heart disease, and baby was not on any decongestive medications. This
forehead sweating, is it a hot sweat or a cold sweat?
It is a
cold sweat. Why?
Because of increased sympathetic activity.
Yes. Continue.
Mother noticed a delay in attaining milestones, and the baby did not attain social smile or head control. Details are included in the developmental history.
Now, in your previous slide, you have told about the cardiac symptoms.
Yes, sir.
Nowadays, it is mandatory for every baby to undergo a cardiac screening, no?
What is that?
For critical heart disease.
Sir? Yes, sir. Yes, sir.
Whether they have done this, did the mother tell anything about this history? Whether they have seen the baby?
No, sir. Mother didn't say anything.
Do NICU babies also require that screening?
Yes, sir.
So in NICU also, baby should be subjected to the screening. Whatever be the skill of the clinician, this cardiac screening is mandatory for babies admitted in NICU also. Huh?
What is the screening that you do, Divya?
Hyperoxia test.
Hyperoxia test. We are not asking about hyperoxia test. What cardiac
For
screening?
all the babies, all
We
babies.
have to look for the
Pre-ductal and post-ductal saturation.
saturation difference more than 5%, more than 3% difference between the upper limb and lower limb, or if it is less than 95%, you should take it as significant.
Pre-ductal and post-ductal. And you have mentioned that there is no details of newborn screening done. What are the newborn screening? One is this.
Dried blood spot, we can look for metabolic screening, thyroid test. Then we can look for autoacoustic emission for hearing and vision in case the baby was a preterm baby with prolonged oxygen.
And since the baby is in NICU for a long time, we can do an ROP screening also.
Yes. Ramachandran sir is asking again, what is the birth weight?
Birth weight is 2.8, I think.
2.8 kg they have told.
Yeah.
Now, the purpose of asking that question whether ROP is mandatory for a term baby who is 2.8 kg.
No, sir.
Huh?
No, sir.
Yes. So once it becomes term and 2.8, only when it's on the borderline preterm, then it becomes very important. A term severe hypoxia term baby does not go for ROP. Huh?
Continue.
History of squint was present. History of regurgitation of feeds present. Baby does not turn on calling name. There's no history of
What
hoarseness.
age do they do that?
7 months.
Right.
No history of hoarseness, drooling, facial asymmetry while crying, and baby is able to sleep with eyes fully closed. History of difficulty in changing the diapers is present. There is no history of early hand preference or decreased movement of any limb. And baby is able to turn head side to side. History of crying for wet diapers and due to pain is present. History of infrequent passage of pellet stools is present. There is no history
What does that mean? What does that mean? Infrequent passage may be seen in many babies. They don't pass for 2 days, then they pass. What is this?
Constipation, ma'am, because pellet-like stools, the sausage shape has lost its water and is broken down to pellets.
So it
indicates constipation.
So if a baby is telling constipation, developmental delay, what will be in your mind?
Hypothyroidism.
Okay, continue. And you must assess the feeding also, no? Continue.
There's no history of seizures, no history of recurrent vomiting, no history of abnormal order of urine, and no history of similar illness in the family.
In the baby with birth asphyxia, what specific type of seizures you are going to ask with that significant hypoxia when the bleed was started on day 7, which are always missed in majority of cases? It is epileptic spasm. You're right. West syndrome. What are the components of West syndrome?
Sudden drop attacks.
Hypsarrhythmia. Then
sudden drop attacks will be there.
Developmental regression and epileptic spasms. So this is one of the very common history you have to always ask in a kid with birth asphyxia. They will have the salam spasms. The head will drop and the hands will come in the midline. So can be a flexor extensor spasm, but at this level, we should always ask for a history of epileptic spasms in a kid with a history of hypoxia at birth.
Can seizures come later?
Yes, ma'am.
Yes, scarring may be there. Seizures can come later also. Okay, continue.
Dietary history. Express breast milk was given only for 2 weeks and baby was on formula feeds. Complementary feeding was started at 8 months with ragi porridge and biscuit is in liquid form, and she stopped the formula feeds. Initially, when the baby came to OP, she was 6 kg. The cardiologist saw the baby and he asked for an advice for weight gain for cardiac intervention. The dietary advice was given by my co-PGs. Initially,
So at birth, first when you saw,
first, an OPD basis, first initially when we are taking history, the child was taking 2 teaspoons of ragi in liquid form, each 3 times per day, and 2 biscuits in liquid form, each 3 times per day. You given using Haberman's nipple. No fluid or vegetables were taken, and it is given in a fluid form. So the energy is basically in hypodense form. And according to ICMR 2020, the requirement is energy requirement is 670 kilocalories and the protein is 10.5 grams. But the intake is only 250 kilocalories and 5 grams with a deficit of 420 kilocalories and 5.5 grams of protein. That is inadequate intake of calories, proteins, and micronutrients. So we started the baby on therapy.
Okay, one minute. Here I want to tell all the postgraduates that because some of you may be wondering, ICMR is prescribing for 6 months to 1 year baby 670 calories, and 1 year suddenly they jump to 1040 or 1070, like that they jump. So what is it? That is, they are speaking about the complementary feeding, assuming that the babies are also getting breast milk. If they put this time the requirement as 1000 kilocalories, all the babies will get 1000 plus the breast milk. So almost 50% of their total requirement may be still coming from breast milk if they are on breast milk frequently. That may be the reason. So this jump is there. Okay, continue.
So we started the baby with therapeutic food.
So the therapeutic there, we have treated this case as a MAM case. So in view of asymptomatic congenital heart disease, we have restricted the
What is MAM? What is MAM?
moderate malnutrition.
Okay.
So in asymptomatic congenital heart disease, we restricted the fluid to 125 ml per kg per day and protein intake to 3 gram per kg per day. So we are given in the form of
what is the upper limit of fluid, energy, and protein that you can give during therapeutic diet?
150 ml per kg per day.
No, in SAM we go to even 200. No,
200.
you can go to 200 kilocalories, 200 ml, F100, and protein. What is the upper limit? F100, 200, F100, 200 ml. You can go. If the baby is not having heart disease, you can go up to 150 to 200. That is 6 gram per kg per day. Okay, that is the upper limit. So in MAM, so first did you do appetite test for this baby? Was it good? This was a cold case who came for evaluation and cardiac intervention. So not having any medical complications. So appetite test would have been good. Then only you can go for this diet. Suppose the appetite test, whether it is MAM or SAM, if the appetite test baby is not having appetite and refusing, then there are some medical complications like sepsis, electrolyte imbalance. You will have to correct that, and then only you can go for this therapeutic feeding. Okay. So how did you achieve the therapeutic feeding and what was the result?
So we have started as energy as an isodex preparation, that is in 100 ml, we get 100 kilocalorie. So the total requirement for this baby is 750 kilocalorie per day with a protein requirement of 18 gram protein per day. So we have divided this 750 kilocalorie into 6 feeds was given.
What is the stomach capacity of the baby?
30 ml per kg, ma'am. 30 ml, ma'am. 30 ml. 20 ml we can consider, and for rest of the 10 ml as gastric enzymes and air.
So you feed 20 ml per kg.
20 ml, ma'am.
Into to 120 ml. Okay.
Yes, ma'am.
So you gave, how did you do it? Okay. What did you give? How did you give?
We have given an indigenous RUSF with modified SAT, as RUSF packet is ready to use supplement feeding, ma'am. As the packet is not available here, we started as a modified SAT mix in which usual SAT mix contain wheat, bangagram and sugar. But here we use ragi as the baby is previously on ragi on that. So here we taken as 1:1:1:1 ratio of roasted puff rice with ragi, black gram and sugar. And from the above portion of SAT mix, we have taken a 3 portion with one portion of skimmed milk powder and 1 portion of MCT oil. And we have given this as a 6 feet with 25 gram diluted in 125 ml of water. So this 125 ml will give us a 125 kilocalories and isodense.
Yes.
So we get a adequate of 750 kilocalorie and a protein requirement of 22.5 gram. So we noticed
You
around
decided to meet the goal, but did the baby accept?
yes, ma'am. Initially, it was difficult to accept, but later we started with the spoon feeding, and it's okay, ma'am. The baby started to accepting, and there was weight gain also noted, ma'am.
Baby had tongue thrust, no?
Yes, ma'am.
So how did you manage that?
And we started giving spoon feeding in the latter towards the left side of the tongue. Since the baby is having cleft palate and everything, towards the left side of the cheek, we started, ma'am, with spoon feeding. Initially, it was very difficult, but later baby started tolerating, ma'am.
Okay. And what was the result of this therapy?
Baby was started gaining weight. Around a 500 gram weight gain was noted, ma'am, within 2 weeks.
Continue.
And also we supplement micronutrients to prevent some micronutrient deficiency. We given potassium chloride as a syrup, pot chlorin 2 ml BD, and multivitamins with syrup Mac total as 5 ml BD was given, ma'am, to prevent micronutrient deficiency.
How did you give copper?
Huh?
How did you give copper?
Copper was present in that syrup Mac total.
Mac total.
Yes.
It's a multivitamin form.
Okay.
Development history, gross motor, baby lifts head momentarily at 10 months, which corresponds to a developmental age of 1 month. Fine motor, baby has hand to mouth coordination, which was seen at 10 months, and the developmental age corresponds to 3 months. Social, baby watches mother's face when she talks to her at 10 months, and developmental age corresponds to 1 month. Language, the baby started to coo at 8 months, which corresponds to a developmental age of 2 months. And vision and hearing, a baby cannot follow lights or objects, and the baby does not respond to name.
What that implies? Doesn't fix and follow light?
So probably the vision could have been impaired, and hearing also was impaired.
What is the term for it? Cortical visual impairment, CVI?
Immunization history. The baby took vaccination till 3.5 months, and 9-month vaccination was not taken. BCG scar was present. There was no adverse effects following immunization, and so the baby is partially immunized according to national immunization schedule.
So when are you going to give the vaccination?
You can plan at the time of discharge.
At the earliest opportunity, once the baby is stable, you must give. Otherwise, they may not come back for the vaccination. Okay. Continue.
Family history, the baby is born from a non-consanguineous parentage, and the age of the father is 33 years. Age of the mother is 31 years. The baby has a sibling who is a 3-year-old brother, and he's a normal child. There's no family history of congenital heart disease or developmental delay, and there's no history of family members with physical disability or recurrent abortions or hearing impairment or any fetal or neonatal death.
Which heart disease can run in families?
ASD can run in families.
Monogenic disorders. Can you give examples?
ASD.
Then? Genetic cardiac defects. What are they?
Holterams.
PDA can run DiGeorge. What is the heart disease in DiGeorge syndrome?
Conotruncal anomalies.
Yes. Can she continue?
Yeah, continue.
Yes, continue.
Socioeconomic history. Father is studied up till 5th standard, and he's a driver, and mother is homemaker, studied up to 8th standard. Monthly income is around 10,000 rupees. And according to modified Kuppusamy socioeconomic scale 2021, the score comes around 10, which is upper lower class 4. And they live in a Pakka house with sanitary facilities are present, and there is no history of overcrowding.
Ramachandran sir is asking any interventions done.
Yes, sir. Intervention was done 10 days before I examined the baby, sir.
Continue.
Will be coming to.
So you have the so you have put up the social Kuppaswamy scale. What is the difference from 2020 and 2021?
The monthly income has decreased. The pricing has decreased.
That is because of COVID, maybe. Many are jobless. So sir is asking about physiotherapy and occupational therapy.
No, sir, it was not started.
Maybe the mother was doing it, no?
For the high-risk neonates, what is the name of the program which we should start in nursery itself?
For promoting, supporting very good development or growth, what practices we call nowadays?
What is
So
that?
it's the early intervention
Is
program.
asking,
Every PD will be telling that, no?
are you aware of DSC? What is the DSC?
District
No,
early intervention.
not district, no.
She
Sir
is
wants to
telling the
know
RBS
what is DSC?
program.
4D, sir. Developmental.
No,
No, regarding
that
this
is the
another.
screening. That is the
Another
screening
one.
and intervention. But what is the intervention in a nursery?
District early
Development. And your history can should contain also the behavioral state, the sleep state, all that giving clues to the problems, overall problems. It's just not the growth alone. It is so much on development of the behavior also. And the state of the baby. That gives you clue how much probably you can intervene. The child had convulsions?
No.
No, sir.
No. So this little strange, a baby with severe birth asphyxia, not having convulsions. No? So that history, did you tell whether convulsions are present or not during?
Yes, sir.
Fine.
She
So what is that care called? Package of care that is given to baby in a nursery to promote good development or support good practices. Called developmentally supportive care. Developmentally supportive
screening.
Care. Okay, proceed.
You always say no infant stimulation, early intervention. So related terms you must bring.
Now a lot of norms are laid down how a nursery should function. Okay, how from sound to light to intervention to feeding schedules, how they should be planned. That will probably support good baby's sleep state or arousal state, and then reduce the injury to the baby. Okay, there's a lot of injury that we induce apart from the needle pricks or invasive interventions, but there's so many things. So attending to all of them is packaged under a term called developmental supportive care in ICU.
Sir, Ramachandran sir asking, are they getting any financial support?
They're enrolled under RBSK scheme, sir.
Yeah, so this cardiac intervention was done
Under the scheme.
Musri Mogambiga Institute is a private institution, but this is accredited for this intervention. So they got all the package for the investigation and the management. Yes, they got financially. Continue.
Course in the hospital, child was evaluated. Therapeutic feeding with ready-to-use supplementary feeding was given, and weight gain was noted. Baby was taken up for cardiac intervention on 31st July 2021, and baby was shifted to pediatric ward and examined on post-op day 10. Summary. This is a 10 months old female infant, was the second child born out of non-consanguineous marriage with uneventful antenatal history, born by cesarean section with birth weight of 2.8 kgs, and there was history of birth asphyxia was present, and history of NICU stay for 35 days, the detail of which is not known. And the baby is diagnosed to have cleft palate, acyanotic congenital heart disease with post-intervention done, and there is no direct breastfeeding given. And baby was in formula feeds till 8 months using Haberman nipple. Now on dilute ragi and biscuits feeds only by the time of admission, which was later corrected with a severe global developmental delay without progression or worsening of symptoms and past history of 2 episodes of respiratory illness, which was probably aspiration pneumonia.
Ramachandran sir has passed on the message that they are entitled to get 1,500 rupees per month as a social support from the government. They should get the disability certificate and register with them. What is the CHD? What is the heart disease as per history? You analyze the history. You said
It is a acyanotic congenital heart disease, and the baby did not have any failure symptoms, and it is a left to right shunt.
No cyanotic spells also.
No cyanotic.
So what is the probable chances?
Because it is a term baby, I would think of BSD first, sir. Then it could be a PDA, and ASD usually will manifest later, but might be ACT also.
So with this intervention was done.
What was the reason for operating so early for this VSD?
The baby had chronic malnutrition.
So what was your assessment for the reason for chronic malnutrition here?
That is, baby had weight gain was poor, sir.
Why?
Because of improper feeding practices,
So
and
it was
also
mainly related to feeding and provision of nutrition. Nothing was to be done to the heart.
Cardiac.
Heart was a CCF or cyanotic heart disease was not responsible for that malnutrition.
So do you think it was VSD or anything else? VSD,
Okay.
we always wait
for the closure. So it could be a PDA, sir. It could be a moderate or moderate PDA, sir.
Okay. So here the heart disease was not the reason for failure to grow. Okay. So it was the provision of nutrition that was lacking that you have corrected. No, after which they have seen market improvement. Huh?
Why
So in those situations, a VSD that is silent and asymptomatic here, no, you have attempted in a severely asphyxiated child when there are other things to attend, adding to some more morbidity to this child. Okay.
So what you said it could be PDA. Did you get any other clue that it could be PDA? Unlike VSD.
Based on the intervention, baby had a scar on the upper right thigh. So usually it could have been a device closure the baby has undergone.
Another thing is associated congenital anomalies.
So the dictum nowadays has become diagnosis of VSD is an indication for surgery. Some interventions, no? From days when you were waiting for VSD to spontaneously close, because there is a chance of closure of small VSDs, especially perimembranous or definitely muscular. Now, because now the surgery is freely available and more surgeons are available, it looks like as if the indication is wrongly applied for surgeries. No?
Yes. Well, actually, what did the baby have? It was PDA. Can she continue?
She continue, madam.
Continue. Divya.
General examination. Baby posture is a baby lying supine on bed, and baby was awake and tongue thrust was present. Vitals, pulse was 132 per minute, regular, normal volume, and all peripheral pulses were felt bilaterally. There is no radial or radiofemoral delay. Temperature was 98.7 degrees Fahrenheit. Respiratory rate was 48 per minute, which was high normal. BP is 90-60 mmHg in the right arm. SpO2 in the right upper limb was 100% in room air, and left lower limb was 98% in the room air. And capillary refill time was less than 2 seconds, and GRBS was 104 mg per deciliter.
How many vitals do you record?
7 vitals.
All the 7 you have done.
Is this the picture of that baby?
Yes, sir.
Okay. Is there any clues from the look the baby is giving for you to decide on any aspect of development in this child?
Yes, sir. Baby is having tongue thrust and baby is having squint also.
Okay. Anything else the babies look? Is it intently looking at you?
Sir, yes, sir.
So this is intently
Icon.
looking at you. So it is capable of making eye contact, no?
Yes, sir.
Eye contact. And so here probably, though baby could have some motor developmental, this baby's cognition may be normal. Okay. So the way the baby is looking at you, no, with an intent and looking at you for a social retaliation, probably it's a clues for knowing whether baby's cognition or social adaptives affected or not. Huh?
Yes.
Go ahead.
Continue.
And the shape of the head is normal and AF is closed. No, there's no riding of sutures. No dysmorphic facies are noted. There's a
So it is
concomitant.
closed earlier, 10 months. You want to say it's earlier?
Sir?
10 months, no, baby?
Yes, yes,
AF
sir.
closed. Is it normal?
What is normal? Sir? AF
Closure
closed.
of AF.
Yes, sir. Inner table was closed, sir.
So outer table is still there. Huh?
A little bit.
Okay.
Concomitant squint is present in the right eye. Cataract is present in the right eye. Tongue thrust is present. There is a small cleft involving the soft palate on the right side of the uvula, and there are 4 central incisors are present. There is also an accessory.
Go back to that picture. What it may look like a spasm, no? We don't know when you caught that picture. You I think from a video you adapted this, huh? This picture.
Maybe it was
video, I think. Otherwise, it looks like a spasm.
Yeah, the movement of that limb posture, the limb posture is indicating a spasm. No, that fluid and there is an asymmetry in the posture of the upper limb itself. Okay.
Continue.
Accessory nipple is present on the left 3 centimeter above the normal nipple. There is no pallor icterus
Any significance for accessory nipple?
Can be associated with cardiac diseases and renal diseases also. Thoracic.
No, hypoplastic nipples may be associated with cardiac defects, but accessory nipples never associated. You can have up to 3 to 4 nipples along the nipple line, but they do not have any importance of its association with heart diseases. But if you have an absent nipple or hypoplastic, then probably you can attach significance.
Yes. There is no pallor icterus cyanosis, clubbing, edema, or lymphadenopathy.
Was this baby given transfusion? Packed red cells?
Yes, ma'am.
Pre-intervention as well as during intervention? Was it given? Pre-intervention. Okay.
Persistent fisting is present. A depigmented patch of size
What does that mean? What does that mean to you?
Persistent cortical thumb persisting more than 6 months is significant. More than 2 months is significant.
What is the significance?
Could be an early indicator of CP.
Cortical damage. If some were adducted.
Depigmented patch of size 7 to 3 centimeters present on the medial, and a macula 4 into 2 centimeter is present on the anterior aspect of the right upper thigh, which is suggestive of nevus anemicus. No other cutaneous markers are noted, and dressing is present in the right upper thigh due to cardiac intervention. Spine is normal, and this is the depigmented lesion.
This baby with dysmorphic features and nevi, what clue this gives you to the possible etiology? If you can consider
neurocutaneous syndromes.
In this scenario, with a cataract, congenital heart disease,
rubella, congenital rubella syndrome.
Any chromosomal anomalies you can consider here? Mosaics. What is mosaic?
Translocation.
What is chromosomal mosaic?
They say mosaic, what actually they mean. So 2 cell lines. Okay. 2 cell lines.
Normal.
One with normal karyotype, another with an abnormal karyotype.
So some of the mosaics, if you get a biopsy of the skin from this so-called nevi, you can get a mosaic kind of a pattern in the skin fibroblast, and in the blood you can get a female karyotype. So then we can conclude that this is some chromosomal anomaly with a mosaicism that can explain congenital heart disease, developmental delay, and then the birth asphyxia. So I was just trying to correlate at the etiology, possible etiology.
Yes.
Please proceed.
Yes.
Assessment of growth by anthropometry. Weight for age, the baby observed weight was 6.5 kg, which was noticed after the intervention. Expected is 8.4 kg. It comes to 77.3% according to IAP and falls less than third centile and comes between -2 and -3 standard deviation. Length for age was 63 centimeter against an expected of 71.5 centimeter, and it is 88.1%, which is less than third centile, coming to less than -3 standard deviation. So it is a severe stunting. Weight for length is 6.5 kg, which against the expected of 6.5, it is 100%. And head circumference is 43 centimeter, and it comes between 0 to -1 standard deviation. And mid upper arm is 12.5 centimeter, which comes between the -1 and -2 standard deviation. So the baby has moderately underweight, severe stunting, and no wasting is seen.
Why no wasting? You said the baby's diet was so poor.
After the intervention, initially it was ma'am was there, ma'am, but after the therapeutic feeding was given, the weight gain was noted.
So your co-PGs did a good job. That is
Yes.
what you are telling, huh?
Yes.
Okay, you will have to sustain that, huh? Okay. Continue.
These are the growth charts for the baby. And
So when the growth is normal, it is good to have the percentile charts. If the growth is less than third percentile, you should have the Z score to see whether it is low or very low. Sir is asking what is the cause for the stunting. I think length is also less.
chronic malnutrition we can suspect in this case.
That you should say. Wasting
Chronic
was
malnutrition
corrected.
or the short stature could be part of probably the unidentified syndrome in that. Okay.
So part of
That
it is
is
due to
why
chronic
not
malnutrition.
been responding, but the weight has been responding. Once your nutritional intervention, your length growth in both linear as well as weight should increase. But here, your linear has not increased and stayed there itself, but the weight gain has become normal, mid-arm circumference has become normal. So here you can think of probably primarily a growth retardation here, okay? Probably of the genetic etiology or probable part of the syndrome that probably will arrive later. Huh?
Yes, that is it. In malnutrition, it is a mild to moderate stunting. If you see severe stunting, look for other causes of stunting. That is the rule. There are at least 10 causes for a child to be stunted. Severe stunting, you must look for the other causes. That is the learning point here. Okay, continue with the developmental.
Development assessment, gross motor, the developmental age comes to 1 month, so DQ is 10. Fine motor, hand rigor is present, which comes a developmental age of 3 months, and DQ is 30. Language, the DQ is 20, and social adaptive, the DQ comes around 10. Vision and hearing, cataract is present in the right eye, and baby cannot follow light or objects, and so the vision is doubtful and hearing is also doubtful, and the baby needs a formal evaluation for vision and hearing.
So with the cataract in one eye and then the suspected duct, what etiology you can make out here? Possible etiology.
Infection like rubella.
Yeah. What are other manifestations of congenital rubella?
They can have microphthalmia, microcephaly, IUGR would be there. Peripheral pulmonary branch stenosis can be there, sir. And along with that,
Any
hearing and
hematological manifestation?
Sir?
Any hematological manifestation? Hematological?
What is that? What are the 3 blood elements?
Thrombocytopenia.
Yeah.
They can have
Any muffins, muffin cakes?
Blueberry muffin lesions.
Yeah. That's right. What is it? What is it?
That is cutaneous.
From where this term has been brought? What is it? Extramedullary?
Erythropoiesis.
So all the blood elements you must look, RBC, WBC, platelets. Okay. So it is a global developmental delay. So what is global developmental delay? What is the definition?
More than 2 domains should be affected, where gross motor and fine motor is considered as one domain. Social personal is one domain, language and speech, and cognition and activities of daily life.
So more than 2 or more domains were affected.
Yeah.
Where will you grade it? Mild, moderate, severe?
It is severe, ma'am, less than 70.
What is mild? What is moderate? What is severe?
Mild is 80 to 90 is mild, 70 to 80 is moderate, less than 70 is severe.
This is with respect to DQ. When it comes to IQ, that is different. Because we want to intervene early. These are the cutoffs. Okay. Can she go ahead with the system examination?
Yeah.
Higher mental functions, baby is awake and cries when hungry. Cranial nerve examination, cranial nerve 1 is not tested. Visual acuity, baby does not follow light, and field of vision, color vision is not tested. Couldn't be tested, and light reflex, in the right eye cataract is present, but in the left eye it was normal.
So what do you think, cataract should have been intervened or not? What happens if the cataract is not intervened in that time?
Sir, the afferent, the light entry afferent would have been affected. So if the cataract is thick, it is present.
No, the consequence.
Very opaque. Okay. What will happen to the
Consequence.
retina and optic nerve?
Sir, if the, sir?
What will happen to the retina and optic nerve? The cataract is not.
It's not intervened.
Light would not pass through, sir.
So what happens? What happens if light does not pass through?
Perception.
What happens to the retina? The retina will slowly go for disuse atrophy. So the child will start losing vision. From cataract, it becomes a neurologically vision loss. So what do you think here, your first priority would have been cataract or heart disease?
Cataract.
Yeah, cataract. So we have taken up heart here as a priority rather than as cataract, because the more you delay the cataract from getting operated, the more the chances that the vision in the eye, if you are delaying, the restoration of vision will be poor.
That is being planned. Is it being planned?
Yes, ma'am.
Yes.
Okay, proceed.
The baby came to the through the cardiology camp, so that is why this is also being planned.
Cranial nerve 3, 4, and 6, ptosis is not present. This concomitant squint is present in the right eye. Nystagmus is absent. Extraocular movements are present bilaterally, and cataract is present in the right eye. Conjunctival reflex is normal, and jaw jerk is exaggerated.
What does that mean by that?
It means a pseudobulbar upper motor neuron lesion, pseudobulbar neuron.
So Ramachandran sir has written the baby may not be seeing with the left eye, only one eye. With the one eye, the baby is managing. That may be the squint and all that.
Yeah, that gives a false thing as squint. Okay, because baby has got now vision with only one eye. That eye alone takes part in the vision. Okay, so the deviation will be there. That globe alone moves to visualize. So it is not a probable true squint. Okay.
Continue.
Cranial nerve 7, forehead wrinkling is present. Bilateral nasolabial folds are normal. There is no drooling, no deviation of angle of mouth, no facial asymmetry. Cranial nerve 8 does not turn to sound, and there is no startled response.
Where is fundus, sir is asking.
Yes, sir. I'll come to it, sir. Cranial nerve 9 and 10, uvula is in the midline, small cleft is present the right side of the palate, a gag reflex is present on the left side, a palatal reflex is not done, and on the left side, palatal contraction is seen. Cranial nerve level, baby turns the head side to side and there is no deviation of fasciculation. Fundus examination is a white reflex present in the right eye. Left eye, there is no chorioretinitis, no cherry red spot, no evidence of papilledema or optic atrophy.
What are causes of cherry red spot?
Caused by metabolic conditions like GM1 ganglion cirrhosis, Tay-Sachs, Niemann-Pick, Sandoff syndrome.
Okay.
In cherry red spot, which part is abnormal? The cherry red is abnormal or the...
Cherry red is the normal one, ma'am. The surrounding areas, because of the deposition of the storage material,
becomes pale. So this becomes... Right.
Motor system, posture, child is lying down on the bed with arms by the side with flexion at the elbows and knees. Persistent twisting is present. No limb length discrepancy is noted. There is no scissoring. No contractures are seen.
That means some physio would have been going, no? Some mother would have been giving some intervention. Otherwise, we expect
Contractures.
time, no? Contractures. Okay.
180-degree flip test, supine posture, flexion at the elbows and flexed at the knees. Pull to sit, head lag is present. Vertical suspension, there is no lower limb scissoring. Ventral suspension, head is lifted momentarily to the plane of the body. Prone position, a baby lies in flexed posture, turns head side to side. And primitive reflexes, Moro's absent, sucking is present, palmar grasp and plantar grasp is absent. Parachute is not yet developed.
Palmar and plantar grasp present, you said absent.
Present. Bulk equally bilaterally. So there is no discrepancy in the bulk in both. Tone, there's generalized hypertonia, spasticity is noted. Amel-Tyson angle, adductor angle comes around 130 degree. Popliteal angle 140, dorsiflexion 50 degrees. Since the elbow does not cross the midline, so there is hypertonia is present. The Amel-Tyson. And power and all the joints, the power is more than 3/5 in all the range of movement. Reflexes, conjunctival reflex is normal, gag is not done on the right side, but it was normal on the left side. Abdominal is normal and plantar bilaterally it was extensor. Tendon reflexes, jaw jerk is exaggerated, and biceps, triceps, supinator, knees are all jerks are all exaggerated, and ankle is also exaggerated with ankle clonus is present. Sensory system is grossly normal, no cerebellar signs noted, no meningeal signs, skull and spine is normal.
Is adductor spasm more by the angles?
Ma'am, adductor spasm is present, ma'am, like mild but not very simple. Mild to moderate is present.
Wait here. Let us discuss this and then go. So, what did you find out after
your
nervous system
neurological examination?
The power was more than 3/5 and hypertonia is present in all the 4 limbs, and the reflexes are all exaggerated, but jaw jerk is also exaggerated.
So what type of hypertonia? What are the types of hypertonia?
Spasticity, rigidity, and so this baby is having spasticity.
What does that mean? Which part of the brain is affected?
Cortex, upper motor, cortex and subcortex involvement.
Why? But that is pyramidal tract.
Pyramidal
no?
tracts.
Pyramidal tract is affected. Sir is asking about clonus. You mentioned about angle clonus, no?
Yes, ma'am.
Angle clonus is present, she said. And which group of muscles will have more tone?
Extensors.
Gravity or anti-gravity?
Anti-gravity.
Which muscles will go into contractures first?
Flexors will be.
Hmm? This is usually the tendo Achilles, isn't it? They go for a toe walking, dorsiflexion. Hmm.
What are the signs of spasticity? What is
Hypertonia.
asked specifically to your mother?
Difficult in changing diapers.
Or
Then?
keeping the lap on the baby.
Okay. For a grown-up
Mainly
kid?
on the side of the abdomen with both the legs in front. One leg in-
Postural adjustments will all be affected. Huh?
Tiptoe walking is one important sign in the grown-up kids. And scissoring. Why scissoring occurs?
Because of adductor spasms.
In which type of cerebral palsy you get it?
Diplegia, spastic diplegia.
Why?
Because lower limbs are more affected than the upper
Again,
limbs.
why? Again, why?
Why?
Because of watershed areas.
Where?
Preterm babies are more
Common
affected.
preterm babies, where the watershed area is periventricular loop.
Yeah, that's right. Periventricular, correct. And all your fibers to lower limb traverse from that area. So that gets affected and the baby gets a spastic diplegia. Which metabolic disorder is the closest differential for it?
Arginase deficiency.
Yeah. How you diagnose? If you're suspecting arginase.
You can do a metabolic screening.
One simple test. Tell me one simple test.
Hyper.
That's right.
Ammonia.
Urea cycle disorder.
Yes. So looking at the baby, so you said the baby is having spasticity. So we agree to that. The baby is having pyramidal tract involvement. Which other part may be affected, or it is only pyramidal tract? This baby is.
Baby is having global developmental delay also, so maybe cortex can also be affected.
What is the point against cortex here?
Seizures is not there, and babies are awake, and baby does not have any loss of consciousness.
Can she continue?
With that significant hypoxia and the mother denying history of seizures, but the baby is having global developmental delay, any specific test you would like to order on this child? Neurological specific test.
We can do an EEG, sir.
Yeah,
Look
that's
for
right.
any accidents.
It is definitely warranted here.
And one picture, even we thought some spasm we are seeing. Okay, so EEG.
Good, proceed.
Continue.
Cardiovascular system inspection. Central line is present. There's a symmetrical chest wall. Movements are equal and asymmetrical. Apical impulse. There's a visible upper and lateral to the nipple, and there's no other visible pulsation noted. Palpation. The apical impulse is in the left intercostal space, 1 centimeter lateral to the mid-clavicular line. There is no palpable thrill or parasternal heave, and there's no palpable P2. Percussion, the left heart border corresponds to the apex beat. The right heart border corresponds to the right parasternal border. There's no dullness in the second left intercostal space. On auscultation, S1 is best heard at the apex and it is normal. S2 is best heard in the second left intercostal space and is normal intensity. There is no audible S3 or S4 and there is no murmur.
When will the apical impulse come to the fifth left intercostal space?
Around 5 years.
After 4 years. So what is your final comment about the...
There is no cardiomegaly. And there is no pulmonary artery hypertension. There is no residual defect.
would it be surprised there is a murmur now, even after device closure?
If there is any residual defect, we can get any murmur after intervention.
It's not residual defect as such because the defect is closed. But there may be small amount of prolapse and it takes time for the cardiac architecture to change. So the murmur disappears. So some amount of murmurs can be seen in most children who have undergone device closures. Okay, it's not that murmur totally disappears soon after device closures.
What are the devices for PD occlusion?
A coil device can be used, an umbrella.
Okay.
Respiratory system, upper respiratory tract, nose and nasal cavity is normal. Lower respiratory tract inspection, trachea appears to be in the midline, symmetrical chest wall. Movements are equal and symmetrical, and the type of respiration is abdominal thoracic. Palpation, the tactile vocal femidus, it is resonant in all areas, and percussion, all areas are resonant on percussion. Auscultation is normal vesicular breath sounds are present bilaterally, and bilateral air entry is good, and there is no added sound.
See, Ramachandran sir has commented that the post-intervention, the intervention having done on in the femorals, you should not have done the lower limb examination in so detail, neurological examination. Did you hurt the baby?
No, sir, it was 10 post-update 10, so
it was only a dressing, huh? Only dressing was there. It was almost healed. Okay. So that is the
advantage of catheterization. You make the child walk. If it's a walking child, make it walk, and you can start mobilizing the joints right from after the procedure. So these are advantages if you're doing catheterization. So not much restriction on movement.
Cardiovascular system is also normal.
But you must always take the mother into confidence whenever you are doing some examination at intervention side. That care should be taken. Okay. The parent's concern will be too much high when you are examining the lower limb, which has been probable site of some interventions. Okay. Child still could have some pain while doing it.
gastrointestinal system, inspection shape of the abdomen is normal. There is no visible scar, sinuses, peristalsis or dilated veins. Umbilicus is normal. Hernial orifices are free. Palpation per abdomen, it is soft and it is non-tender. Percussion, liver is palpable 1 centimeter below the right costal margin and the span is around 6 centimeters. Spleen is not palpable. Bowel sounds are present and external genitalia is normal.
So one of the differential diagnoses we considered was congenital rubella. So what do you expect in the abdomen?
Hepatosplenomegaly should be there, but it is not.
Yes.
Diagnosis.
Hold it there. Let the teachers clarify all the doubts. Then you can go to the diagnosis. Can she present the diagnosis?
No. What do you think the probable cause here?
Yeah, discuss
Could
and
be
then
birth as any perinatal asphyxia.
But what is the evidence here for perinatal asphyxia?
There was a history of resuscitation needed, sir, at time of birth, and there was also.
So, what do you think would have been the primary reason for that?
Maybe at the time of birth.
Is this a baby who is having defects of the palate, defects of the heart, is also having a congenital defect of the brain? Okay, that's the reason. Here the intrapartum monitoring also it would have got missed. Okay.
Yes. So baby did not cry because the brain was abnormal.
Yeah, brain was abnormal. So what are the conditions that are associated with asphyxia, congenital conditions of the brain?
Any sinus malformations, like any lissencephaly, schizencephaly, or any porencephalic cyst, or any migrational defects.
What is lissencephaly?
Sir, fetal
What
like
is license?
fetal skull
What is
like
lissencephaly?
that
What
is
is lissencephaly?
part of
Yeah.
the skull.
Loss of
Loss of-
iron in the
Sir, listen
Yes,
carefully. Listen carefully. The convolutions are lost. Sir. Look, it gives an appearance of a fetal skull.
Smooth brain. Huh?
Smooth brain.
loss
So
of
it is like a silk. This word lissencephaly has been taken from a word silk. So it is smooth like a
Smooth.
silk. It is one of the neuronal migration disorder.
Hmm.
What are other neuronal migration disorders?
Pachycardia, Cygencephaly.
Yeah.
What is the head circumference, sir is asking? Just Divya.
43 centimeters, sir, which is normal.
It is
Coming at-
low for 10 months,
Low.
but it does not qualify to call it a microcephaly.
Microcephaly.
What is microcephaly?
Less than -3 standard deviation.
What are causes of microcephaly?
Any infections can cause, sir.
Okay.
It could be primary or secondary.
Okay.
Primary could be any autosomal dominant conditions or any intractable infections like TOTS infection, Zika.
Okay.
Zika virus.
Zika.
Along with microcephaly, what Zika causes to the brain?
Mental retardation.
No, it's one of the feature by which they are making the diagnosis also on the imaging also. I think Sarah is referring to that only.
Periventric.
Zika again causes cystic encephalomalacia and your neural migration disorders. So it again causes a disruption in the brain. So one of the very badly disrupting virus. Any other causes of acquired microcephaly in a girl child specifically?
So you see overriding of all the features at birth itself.
Any syndrome where the girl.
Turner syndrome.
No.
A girl child with acquired microcephaly who loses the milestone.
Some peculiar movements also she's having. I'm giving you the clue.
Any midline stereotypies are there? Hand raising movements.
Which syndrome? Girl child.
Rett syndrome.
Yeah.
Rett syndrome.
What mutation it is? It is MECP2. What are the other spectrums of Rett's?
Intellectual disability can be there.
No. Other spectrums, other genetic spectrums. It's FOXG1 and CDKL5. What is the closest differential for a Rett? What is happy puppet?
Angelman syndrome.
Yeah. What is the mutation?
It's a
maternally derived.
Yeah. What is it?
Epigenetic
Imprinting. Yeah.
It's maybe a methylation defect or uniparental disomy also may be there.
Yeah. What are causes of macrocephaly?
hydrocephalus.
toxoplasma,
white matter diseases, Canavan's,
What is the other name of white matter disorders?
leukodystrophies.
Yeah. What they are, under which category the leukodystrophies come? Neurodegenerative disorders. What are the two types of neurodegenerative disorders?
Matters.
Which are two matters in the brain?
Two matters. What are the two matters?
Yeah, gray matter. And the other is?
White matter disease.
White. So what is the other name for gray matter disorders? Poliodystrophies. And for white matter disorders?
Leukodystrophies.
Leukodystrophy. How you differentiate?
Seizures will be presence of seizures and mental retardation more in gray matter disorders.
Yeah. And white matter?
More like motor Less
Yes,
cortical
spasticity,
spasticity,
optic atrophy, ataxia, peripheral neuropathy. What are the differentials for white matter and what are the differentials for gray matter?
For white matter, Alexander's,
Yeah.
Kahneman's.
Yeah.
For gray matter, Crab. And leukodystrophies like metachromatic leukodystrophy,
Yeah.
adrenal leukodystrophies.
Viral
Yeah.
infections. White matter disease.
Poliomyelitis.
Yes.
What proportion of cerebral palsy would be due to birth asphyxia?
Around 10%.
So now you are incriminating birth asphyxia as a cause for cerebral palsy. You'll be right only 1 in 9 times. Okay. So you need to think more as what probably could be the reason for the baby not crying at birth, and what could be the association with the cleft lip and palate and heart disease, and the shortness of stature also. That would give the probable clues to the primary diagnosis of this case, rather than birth asphyxia alone being incriminated for all of those things. What are the prognostic factors at birth or while in NICU that indicate the child may go for severe motor or neural disabilities?
Delayed feeding is initially later.
Any scoring system?
At birth itself, SAR had initially first told, no? Yeah. Establishing spontaneous breath, no? Spontaneous breath. If it is delayed by more than 5 minutes, that's one clinical parameter soon. Then comes feeding. Then?
Apgar score at 10 minutes, 20 minutes, like that.
An Apgar score.
Then Apgar score.
Tone of the baby.
Not the, okay, tone of the baby.
Any seizures?
Or the posture, asymmetry or posture. Then?
Is any seizures?
Yeah, seizures.
The HI staging you must see.
Yeah. Okay, then anything else? Anything on the biochemistry side also?
Hypoglycemic or electrolyte.
Lactate levels.
Pyruvate and lactate.
Yes, that indicates a severity also. Okay.
Can you present the different? And I think now she will go for the diagnosis. We have 30 minutes more to discuss.
Okay.
Diagnosis is a case of spastic quadriplegia with severe global developmental delay, no seizures, concomitant squint is present in the right eye, cataract is present in the right eye, vision and hearing impairment is present, and the grade 4 of functional class and unilateral.
What is grade 4?
Baby needs custodian care.
No useful?
No purposeful movements with custodian care. Unilateral right cleft palate is present with acyanotic congenital heart disease, most probably PDA with post-intervention. Moderate underweight, severe stunting with no wasting. So it is a case of chronic malnutrition with short stature. Most probable diagnosis is most probably a cerebral palsy with perinatal asphyxia. And the site of involvement could be diffuse with the cortical and subcortical involvement.
So putting together everything, cerebral palsy, we already said. So would you like to have a
differential
etiological diagnosis other than this? Now you are focusing more on the motor disabilities. What about the other anomalies?
Could be
For the etiological diagnosis,
malformation.
what are your pros and what are cons in the DDs?
How many points are in favor? How many points are against? No,
Uh,
Go back to this diagnosis only. Now you are telling everything is due to the perinatal asphyxia. Do
Yes,
you
the
think
first-
so? What are major congenital anomalies? What are minor congenital anomalies? What all these babies have?
Major congenital anomalies are those which require intervention, both surgical, medical, or cosmetically, and the functional performance of the babies are affected. Whereas in minor, does not need any intervention and does not impair the function of the baby.
So how many major malformations this baby is having? How many minor?
This baby is having around 4 major anomalies.
CNS
CNS is affected, heart is affected with vision abnormality and hearing abnormality.
and the palate also, no?
That.
So more than several major malformations. And minor, what did you find?
Minor like squint.
Maybe we can attribute to the nevus that you were speaking about. And so what? So when you have major and minor anomalies, what you should think of?
We should think of any association syndromes associated. Genetic or any
Chromosomal anomalies, associations. Okay. Can you tell any association? You said association. Which association is
charge association can be
Addition or duplication.
Coloboma with heart defects and corneal atresia, growth retardation, renal anomalies, and ear anomalies.
Okay, so we must say that this baby is having major anomalies and the nevus put together, then short stature. Putting all that together, what you would consider first possibility? We have already said that.
Rubella, we can consider congenital rubella.
We must first take the chromosomal anomalies, the
anomalies, genetic causes, or we can think of any CNS malformations and intrauterine infections.
Okay, go to next. You want to tell about intrauterine infection. Tell us about intrauterine infections. Your next slide you showed. So what are the points in favor of rubella? What are the points against rubella?
In favor of rubella, babies having a PDA with a cataract is present and hearing is also impaired, and there is a developmental delays also present. Against this, a baby does not have any IUGR or hepatosplenomegaly was not present, and there was no history of fever or rash in the mother during the antenatal period.
Why it's very most often difficult to get this history of fever with rashes with rubella?
Post-auricular lymphadenopathy.
So no one touches behind their ears to look for that.
It is difficult to get the history.
Okay, most often it goes unnoticed. So that history most of the times, even though mother has had rubella, most of it's so transient, that fever and rashes, that it gets missed. The mother probably attaches less importance and says no to your answers only. Okay. Unlike measles, it doesn't have a very fulminant course. It's so transient with rubella.
Fundus, what do you expect in intrauterine infections?
Chorioretinitis will be there, ma'am. With
the brain, what do you expect?
Calcifications will be there. Intracranial.
Maybe there. Okay. So that is one good bet, but usually they start with IUGR.
This child with PDA with rubella, and it's also a term baby. What will be your take on giving some drugs to close PDA?
We should not give for a term baby, sir.
Okay. So term baby, not that we should not give, probably doesn't respond. It doesn't respond. Then anything else? If it were rubella, will it respond? Will a rubella baby? Huh?
No, sir.
Because that PDA is a diseased PDA. So it doesn't respond to most often your either your ibuprofen or paracetamol. Huh? Okay. Yes. What are the indications for surgery when there is a PDA?
If there is a severe association, like there's a cardiac failure or pulmonary artery hypertension is there, or it is a large PDA, sir, with
When do you call large?
volume overload is present, with failure to thrive, with any PAH, pulmonary artery hypertension, or a CCF is present.
For small PDA to prevent
pulmonary hypertension. Then
for small PDA to prevent infective endarteritis.
Yes.
that's not an indication for immediate surgery. So suppose you want to close it too early in the early period, in the neonatal period itself, there are definitive indications, guidelines that are given. No? If the shunt is more than, systemic to pulmonary shunt is more than
2:1. 2:1.
Okay. Right. What are the drugs they are using now for closure of PDA?
Indomethacin we can use.
Huh?
Indomethacin,
Okay.
Paracetamol.
Yeah.
paracetamol, ibuprofen.
Ibuprofen. Okay.
Which drug is for keeping the PDA open?
Prostaglandins E2.
Okay. So is it necessary to rule out other congenital heart diseases to see whether it is ductus dependent before using this?
Yes, sir.
That dependent.
Yeah. So it is mandatory to know whether this ductus is very essential for a
Maintain the
survival itself. Okay. Only if it's an isolated PDA, then you will attempt a pharmacological closure. Okay.
So what are the other DD that you have brought in?
Baby had a one could be a postnatal neonatal sepsis or like meningitis equally. The points for this is the baby had a prolonged NICU stay for a period of 35 days. Point against this, baby does not have any seizure history.
There is no history of lumbar puncture also, no? Mother has history?
Yes.
No. If it were meningitis, suspected meningitis, CNS infection, they would have done a lumbar puncture.
What are the organisms for neonatal sepsis, meningitis?
Group B streptococcus, gram-negative.
How you treat?
Is it early onset sepsis or late onset sepsis will go for meningitis?
Early onset sepsis.
How do you define early onset and late onset?
Less than 72 hours is early onset, more than 72 hours is late onset.
Usually early onset will not localize. The late onset is the one which goes for meningitis, osteomyelitis, etc.
How you prevent GBS sepsis? Ruby streptococcus sepsis. How do you prevent it?
Like precautions we have to take: hand hygiene, clean cord, clean cut, clean surface.
Which test would you order in a mother?
Any cultures?
Any swabs? Any swabs?
Throat swabs, nasopharyngeal.
Vaginal swabs in the mother.
High vaginal swab is the one which can diagnose it.
Which is the antibiotic of choice for neonatal GBS sepsis?
Crystalline penicillin.
Any other takes? Any other takes?
Broad spectrum.
One specific antibiotic is ampicillin.
Yeah, derived penicillin, beta-lactam antibiotic. Now in our hospital, they are not providing us with crystalline penicillin. I don't know about other hospitals. They are not buying, I think. Only ampicillin we have.
So this baby is having deafness, no? What test you do to confirm this deafness, and what test you do to screen deafness in newborn?
For screening, we can do autoacoustic emission, sir. For confirming,
what is the principle behind that OAE?
that is the outer canal alone, it will detect. So it will hair cells.
No, the principle behind it. Yeah.
The hair cells organ of tortilla.
The hair cells? What happens? What happens to hair cells? What is picked by these transducers there? So the hair cells make noise by the movement.
Sir?
The hair cells make noise by their movement. That is picked up by the transducer in OAE. Okay. Okay, then what are the tests?
Bera we can do for confirmation.
Which one?
Brainstem evoked Bera we
Auditory potentials. Okay. So in this case, you have done Bera?
No, sir. After stabilization, we apply.
Okay, this baby is now 10 months. No. So when do you think you should confirm and do some intervention for the deafness? You can. Early.
OA is done when? Now it is a mandatory newborn.
Yeah. Why? Why it has become mandatory to screen for auditory deafness very early?
Newborn screening.
Because speech can also be affected if.
It definitely will be affected. The more you delay the hearing assessment. Okay, if the hearing is not there, speech is impaired, and then it becomes very difficult to
train the child for.
Yeah, rehabilitate them in speech, even if you are putting a cochlear transplant. Okay. So what is the ideal period by which you must identify and do the cochlear implant surgery? Beyond which you will not see much improvement, even if you are doing. So as early as by 6 months to 2 years, you must have completed it. Okay. So any delay beyond the time, actually the effect is not good. The outcome is not good.
Among the torch infections, which is the one which affects hearing?
Rubella.
And? CMV?
CMV also.
Okay. Which one of them is treatable? Which all are treatable among torch? Whether toxo is treatable?
Yes.
With what?
What is the drug they are using?
Sulfadiazine and pyrimethamine. Whether CMV is treatable, congenital CMV?
And spiromycin. Okay. So toxoplasmosis is treatable. Treatable. CMV is treatable?
Ganciclovir we can use.
Yeah.
Yeah. What is the other alternative for ganciclovir?
Acyclovir.
Valganciclovir. Valganciclovir. What is one specific thing which you want to improve on the long-term outcome when you are treating with valganciclovir or ganciclovir in the case of CMV? So it is hearing impairment which we are treating. It is not the microcephaly which is going to be there anyhow. So it's only the hearing impairment which we are targeting by treating a congenital CMV. How you diagnose it?
I do MRI and fundoscopy.
No.
Confirmatory diagnosis of a congenital CMV.
Virus detection or?
You can send for a torch screening.
No.
With IgG.
Any PCR test you would like to run? What is PCR?
Polymerase chain reaction.
Yeah. Any specific PCR test you would like to run on a kid with suspected CMV?
Real time.
What
not
specimen?
viral,
What
we are looking
specimen
at
you would
viral
ask?
load. Okay, viral load is very important.
In which all specimen you can test?
CSF, blood, urine.
Yeah, urine, saliva, yes.
So urine CMV PCR, you have to see the viral load and then you confirm and treat it for 6 weeks.
So, will rubella recur in subsequent pregnancy?
No, sir. It's a long-term antibody will be formed. Lifelong immunity will get from single infection.
Beg your pardon?
So from single infection, lifelong immunity will be there. So further
Subsequent
pregnancy will
pregnancy
not be affected.
will not have any influence. Okay.
CME?
Which
What about CME?
infections will keep recurring and
Syphilis
causing
can,
physical damage?
syphilis,
Yes.
Syphilis,
HIV,
HIV, and
cytomegalovirus.
CMV.
CMV,
Yeah, CME.
toxoplasmosis. Okay.
So now you have the rest of it. See, I have asked them to put up some teaching slides also. Shall we move? CNS malformations that we discussed, I think, isn't it?
Yeah.
Yeah. So genetic causes. What have you written?
Urea cycle disorder like arginase deficiency, leukodystrophies.
Sometimes no. 2 children having diplegia, then that may be the clue that this may be, or consanguineous marriage. Okay. Okay, continue.
Investigations, what we can plan for this. We can do a complete blood count, peripheral smear, urine routine, look for the hygiene of the child, vision and hearing evaluation, TOD screening, thyroid function test. You can do an ECG, chest X-ray, echo, ultrasound, abdomen.
What is the now role for TOD screening so late? No?
No.
Yeah. So it will not be useful after much damage has been done, even if you have CMV and you have a drug, or toxoplasmosis and you have a drug. Because here is a child with no seizures.
What else we said it should be done? Anything? During discussion we said we should add one.
EEG we can.
EEG. Yes, EEG we said. That also should be added.
Management, we can plan for this child, correction of feeding practices which is done, and micronutrient supplementation, multidisciplinary approach with a neurodevelopmental patterning and infant stimulation program, muscle relaxants to relieve spasticity.
Which muscle relaxant?
We can give tizanidine or baclofen, we can diazepam.
Not in the infancy, diazepam as muscle relaxants for cerebral palsy. The most common preferred would be baclofen, and some people are using botulinum toxin in little older infants. Okay.
Correction of congenital defects, fixation.
They are also using the anti-Parkinson drugs to relax the muscles. Okay.
Congenital heart disease interventions done, cleft palate and cataract, and catch-up immunization.
Do you think that child's vision in the right eye will improve after cataract surgery?
Multiple areas are affected in brain, cortical.
Child had cataract from birth, ma'am. It was developed earlier. We can replace it with intraocular lens.
What do you think will be the prognosis of this child?
Prognosis is guarded for this child, ma'am, because even at 10 months, the head control has not been attained. And baby is having a severe global developmental delay. with hearing is impaired and vision is also seem to be having impaired. And guarded prognosis.
But still a lot of time is still left for intervention, no? Because you have brain growth till 2 years of age. Huh? So a lot could be done still, though the prognosis may be guarded because you have not seen much improvement in the motor function, no? But still you have time for nerve cells to still continue to learn and keep on undergoing more neural connections. Understand? So the child's prognosis could improve if the stimulation and intervention is perfect. Okay.
So Ramachandran sir also has said, tell the good things first. If we ask what is the prognosis, they see the baby has responded to your nutritional intervention, no? The baby regained weight for length. So the wasting is corrected. Now you have to work on the rest of the things, the vision. So many things can be done for this baby. Put it positive. Okay.
Any imaging investigation which is going to help you for the prognostication here?
MRI we can.
Yeah.
MRI.
Yes.
What is
MRI
the red cam they are now using? You know red cam? RETCAM? Red cam is primarily used for screening ROP, but it also picks up more of the eye defects more than ROP, and it's one of the screening tool nowadays that is being used apart from indirect ophthalmoscopy to find out cataract, to find out tumors of the eye, to find out problems with the retina also. Retina also. So red cam is one device that is becoming popular in pediatric ophthalmology, especially neonatal screenings.
What time we should intervene for the cleft palate?
Yeah, by 1 year of age or by the rule of 10 we can.
What is the rule of 10?
More than 10 hemoglobin, more than 10 kgs and more than 10 weeks of age.
Then?
10 months of age.
Before the speech develops, you should intervene. Otherwise, they will,
1 year old.
patient will be different, even if you correct.
But this dictum is slowly fading because sometimes unless the cleft palate is corrected, you never will get up to 10 kg. Okay. So the period of growth is lost. So you will have to balance that and pick up and do it early. If the child is thriving well, then probably you wait for the safe weight. Otherwise, if the child is not thriving, you have to go ahead and do it early. And they are now doing it as early as 9 months also. Okay, cleft palate, and not wait for beyond 1 year of age.
Cleft lip, when we should do?
Right, 16 weeks earlier, ma'am, we should do by 3 months, 3 months to 6 months.
10 weeks.
10 weeks. That is the 10 weeks that is.
10 weeks for that.
10 pounds, 10 weeks, they used to say.
10 grams.
So
Okay, so you can ask her to do the discussion, madam.
the discussion, I think I had put up some slides. We'll rush through that and then discuss. Okay, continue that slides. So when in cerebral palsy, we should make a topographic diagnosis. So go back. Where does your child fall in this group? Topographic.
Quadriplegia.
The difference between quadriplegia and double hemiplegia.
Quadriplegia, all 4 limbs are affected, along with the trunk and neck muscle also affected. In double hemiplegia, upper limb is more affected than the lower limb.
Then we should have the physiological part that where does this baby fall?
Spasticity.
And the functional limitation you said, no purposeful movement, custodian care. The etiology we try to put it into perinatal, prenatal, etc. Any other functional classification is there? You have put any other? For walking children, we can do C.
Gross motor functional classification.
Yes.
Yes, you can also add, just for the sake of completion, I have added this. So when a baby is very small, you can go for the other classification. Otherwise, we can go for this GMFCS. So any other classification for hypertonia, etc.?
Modified Ashworth scale.
Where does this baby fall?
1 plus.
1 plus, what is 1 plus?
There's a slight increase in tone and the range of movement is resisted, but it is less than 50% of the range of movement.
Okay. You must add points here. Dr. Abhijit and Arsa sir. Can she
No, ma'am.
continue? I think our time is getting over. Next slide.
Yeah.
So we can use this for, this is a visual impression of the hemiplegia, the diplegia, quadriplegia, ethetoid, dystonic, ataxic. The more disability will be with which type of
Quadriplegia and dystonic or dystonic also.
the dystonic, the tongue is also affected.
Which type of babies are going to get dystonic cerebral palsy?
Those with kernicterus,
Bilirubin-induced neurological
choriothetoids.
damage.
What is the other name for kernicterus?
Bilirubin-induced neurological damage.
Dysfunction.
Yeah. Fine. Why they go into dystonia?
Because
Extracerebral
basal ganglia,
ganglia.
there will be deposition of bilirubin.
Yeah.
Where?
Bilirubin acid in the basal ganglia.
The extrapyramidal.
Extrapyramidal system.
Yes, continue.
Any gaze abnormality they develop?
But gaze palsy will be there, sir.
Which one?
Gait, sir. Gaze.
Which gaze palsy?
Upward gaze palsy will be there, sir. Cranial.
Up gaze. Up gaze will be affected. Yeah. Spastic quadriplegia. Any differentials for it?
Go back. There.
Spastic quadriplegia, we can think of molybdenum cofactor deficiency, sulfite oxidase deficiency.
Yeah. How you diagnose MoCo? Molybdenum cofactor is called as MoCo and sulfite oxidase. How you diagnose them? Urinary sulfite levels you have to ask. And fundus, anything special? Glistening dots are seen there in the fundus. So they again have cystic encephalomalacia. What your spastic quadriparetic cerebral palsy kids are going to have due to birth asphyxia. Your sulfite oxidase and MoCo both have again the same kind of multicystic encephalomalacia. Why it is important to diagnose?
The treatment will change and the prognosis, and if it is a genetic condition, the other children may also be affected. Success of pregnancies.
Yeah. So you have to counsel them for a prenatal workup. For the recessive disorders, what is the recurrence risk?
25% recurrence will be there, sir.
25% recurrence is going to be there. So you have to identify that particular mutation in the index case, then go for Sanger sequencing, get a specific mutation in both the parents, mother and the father, and then prognosticate to the family. So that is how you complete the loop of a prenatal counseling.
So in relation to asphyxia, what is the NIRS nowadays they have started using in NICUs? NIRS. What does it measure? Does it have any role?
If you don't know, you say you don't know. Then
So
sir will tell you.
Near infrared spectroscopy is one. It's a device that measures the blood flow and the hypoxia and ischemia to the part. So whenever there is hypoxia, ischemia, it can be measured with NIRS. Even when the child is sick and shock, you can know whether cerebral hypoxia is happening or ischemia is happening. It's a new tool that is being used in the NICU for monitoring the severity of hypoxia and asphyxia.
Okay, continue to the next. So I think she has listed most of the conditions. Huh? Slowly progressive leukodystrophies. Then in infantile stroke, hemiplegic type of cerebral palsy, we have to consider the thrombophilic conditions. I think the rest of the things we have discussed.
Yes.
This perhaps go back. I think we have discussed the nutritional management, the cataract, cleft palate, CHD, and neurodevelopment. Next. So all student PGs are very eager to tell about multidisciplinary approach, no? Even UGs. So my question is, who is the key person in the team?
Mother is the
Yes. And who should be the team leader? Who will coordinate?
pediatrician.
Custodian of the baby. Other than the mother. The pediatrician. It is our responsibility to coordinate all these specialists to come and help this baby. You have any slides? Prevention. How will you prevent? It is not difficult. It is not easy to prevent because they say that what is the incidence or prevalence of cerebral palsy?
Around 30, 15
per 1,000.
2 to 2.5 per 1,000 life growth.
And even with good obstetric care, this prevalence has not come down. That is why they say, as we discussed, maybe the brain is abnormal. That is why the baby did not cry. But you can read this quickly and go to the next slide. We can prevent which all intrauterine infections. We said no rubella. Then prevention of birth asphyxia. Go back.
chorioamnitis management, iron supplementation, steroids to the mother and preterm labor, magnesium sulfate for tocolysis, and early markers are the target milestone.
Steroid in the first trimester.
Magnesium sulfate, not only for tocolysis, magnesium sulfate is now used as a neuroprotective drug also.
Brain protection.
So kindly include, apart from tocolysis, in preterm deliveries, it is one of the drug used for neural protection.
Neuroprotection. That is the thing. And steroid in the first trimester, which defect can come?
It can cause
Cleft.
Yes.
Okay, go to the next. What is there? What are these target milestones? You can just rush through that. Read.
lack of social smile by 2 months, and absence of stable head control by 4 months, inability to recognize the mother, and inability to sit when pulled to sit up by 6 months, lack of independent sitting with support by 8 months, lack of creeping by 9 months, inability to stand without support by 1 year, and walk without support, walk with support by 1.5 years, and there's no syllable babbling by 1 year, failure to make meaningful words by 3 years, and lack of pincer grasp by 1 year.
So these target milestones have to be
corrected to postnatal age in preterm babies. Okay. That is also. Okay.
Next. So I think this is the last slide. So there is a cerebral palsy day. That is
First
this is okay. What is spastic society? I think that is my last question. Spastic society. You can stop the screen share. Let us have face to face. What is spastic society? Like hemophilia society is there. Spastic society is there. I remember that was my DCH question. Theory question, spastic society. That is the society to help these children and the families. It consists of the parents, the well-wishers, NGOs, corporates, doctors, everybody who is interested in the welfare. They can guide them what to do. They may be lost. You can guide them, help them, counsel them, arrange some appliances. Some babies may need orthopedic surgeries. So how they got it, how they manage this wheelchair, everything can be arranged through this family.
Yeah, any question, madam? Yeah.
Over to you, sir.
Yeah, it's actually a wonderful presentation, like exam related, obviously that exam related, and another thing is what's the basic management. That excellent combination of moderator as well as chairperson, and that postgraduate also presented very nicely. I think our judges are there. Dr. Srinivasan, sir. Unmute, sir. Unmute, sir.
Totally and thoroughly discussed case from all angles, from metabolic and this thing. So I think the girl has answered almost with so much of confidence and presented confidently. Okay, so தாக்கு பிடிச்சான்னு தெரியுமா தமிழ்ல? So you're able to face all the questions with the same amount of this thing. Initially, madam was telling you look tense, but then you have done justice by answering most of the questions and trying to this thing. So you never became tired of answering. And of course, every angle has been analyzed.
And the supporters also supported well.
Thank you. Yeah, yeah. So
they were
nice.
shouting like
Yeah, all great people
chorus.
are this thing. Examiners, you are lucky to have them and this thing. Of course, the most important question I would ask is how you would counsel the parents and make them get motivated to continue the therapy. Okay, that is, marks will be given. So that is very important. And also the positive aspects to must always emphasize to the parents. These are the positive things in your child which can give me this thing. So that type of assurance, and then of course negative things you have to tell. That is one important aspect of counseling of a child with multiple problems. Thank you so much.
So Dr. PRC, sir. Yeah.
Thank you, sir. Dr. Rajendra, you should have given 3 times the time. They discussed 3 cases in one.
Yeah.
So, and there was another examiner also in the chat box.
Yeah. Thank you so much, Dr. Divya, Dr. Nusha, and who's the other one?
Anjana.
Anjana, okay. Presented very well, discussed very well. So you faced with lot of equanimity and good confidence. Please keep it up. All the best to all the 3 of you. And thanks to Madam and Arasar and Dr. Abhijit. We keep learning a lot of new year things and updates. Thank you. Thanks for the opportunity.
We also learned a lot. Okay, not only you learned, we also learned. Okay.
Yes, sir. So it's a great experience. Thank you so much.
We learned neurology. We learned also neonatology. All 3 aspects.
And Professor Srinivasan, as I emphasized, what are the things you have to actually, certain additional things you have to concentrate during the management, like counseling, because some examiners may be asking that. They may not be able to do much for cerebral palsy, except motivating the parents. So that part.
But I think this mother has done some physio and all, no? Otherwise, we expect more spasm or dissering. She's doing good job, I think.
Exactly, ma'am.
But the right advice she was not getting regarding diet and all.
Yes, ma'am.
Very good case, very good case.
Dr. Arasar, sir, your comments, sir.
Thank you, sir. They have done a really wonderful work presenting. It takes a lot of effort and a lot of courage also to present a case in front of a forum. And they have done it very nicely. And you are all there in the chat box guiding us also in between as to how the discussion should proceed. Thank you very much, sir.
I would like to advise, whatever questions have been asked, you should write to this thing, before you forget. At least 80% of it you should remember and write down. So these are the questions that will be asked, and invariably there will be 1 or 2 cases kept, okay, in neurology. So kindly remember. So it's not the end of thing. This is the beginning. So many important questions have been asked, and some of the recent advances also have been asked. So kindly remember that. Okay.
Yes, yes.
Thank you.
Dr.
Yeah,
Abhijit,
Abhijit. Yeah, Dr. Abhijit. Yeah, your comments.
Yeah, I would like to congratulate all the three students. They have really nicely presented and had put in a lot of hard work. So best wishes to all three of you. You'll definitely going to do well in your final exams. Just keep it up.
And I am all the more happy because I saw Abhijit after a long time.
Thank you, sir. Same.
Elizabeth, Madam, your comments, final concluding remark.
I am happy that they could do well. They actually did lot of preparation and even a mock presentation like that. They took all the effort, I must say. It was a difficult case, but I thought this is the best case for a forum like this. I'm so thankful to the moderators and the judges and this
Thank you.
platform. Thank you very much.
So they
Thank you.
approved Dr. Elizabeth Madam's postgraduates. Okay, they really they done very well.
Okay.
Yeah, Divya presented very nicely. I think a good presentation. On behalf of IAP TNIC, I thank today's chairperson, Dr. Elizabeth Madam, and postgraduates Divya and team, and today's moderator, Dr. Arasar Siralar, and Dr. Abhijit Patel, and Dr. Srinivasan sir, judge, and as well as PRC sir, and all the postgraduates, those who are attended this presentation today. And on behalf of IAP TNIC, I thank one and all. And it is available in IAP TNIC YouTube channel. And those who want, you can go and whenever you want, you can go and see. It's available. Okay, thank you. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you
Thank you very much.
Good night.
Good night.
Thank you, sir.
Thank you very much. I also learned a lot.
Thank you, sir.